Hello everyone, I am Adi Anisaha. I am an MBBS student from Nepal Medical College, and in this video, I would like to talk with you about acute tubular necrosis, and also it is known as acute tubular injury more often. So nowadays, the term acute tubular necrosis has been converted or has been changed with acute tubular injury, also known as acute kidney injury, because in the foci of lesion, it is not sure sort to find the necrosis in every foci of injury. Hence, the term has been changed to acute tubular injury. So basically, in the last video, I talked with you about the causes of acute renal failure. And acute renal failure nowadays, it is also called as acute kidney injury, because acute kidney injury is the most common cause of acute renal failure itself. And in that video, I talked that there can be pre-renal cause, there can be post-renal cause, and there can even be intrinsic causes. And because of the intrinsic causes can also lead to acute renal failure. And whenever we are talking about the intrinsic causes, it can be damage at the level of glomerulus, or at the level of tubules, or at the level of interstitium. So it can happen that due to damage to this structure, and that will manifest with a decrease in the function of the kidney. And one of the very important function of kidney is to filter out urea and creatinine, as a result of which the urea and creatinine will be increased, and that will manifest with acute renal failure, and the most common cause being the acute kidney injury, or acute tubular necrosis, or acute tubular injury itself. So this is the most common cause of acute renal failure. So whenever we talk about glomerular diseases that leads to acute renal failure, the name comes in our mind is about RPGN. So in RPGN, as I said in that video on RPGN itself, I said that it rapidly progressed to glomerulonephritis, and there has a very short course of duration that will manifest with acute renal failure. So it is one of the very important causes of acute renal failure, and it refers to the glomerular cause of acute renal failure. Not just that, there can be damage to the tubular epithelium. It can be due to drugs. It can be due to drugs like aminoglycosides, gentamicin, amikacin. And regarding these drugs, every drug has its own mechanism of action of damaging to the glomerulus, sorry, not to the glomerulus, to the tubules, because every drug is being handled by the kidney for its excretion, and either they are secreted, and even during the process it can be also absorbed from the kidney, and this is all done by the tubules, and there has been damage to the tubules by this drug, and this will manifest with the inflammation within the tubule, and more often there will be inflammation in the interstitium, leading to interstitial nephritis. And it is important to know that most of the drug will cause interstitial nephritis with massive infiltration of eosinophil and water, leading to interstitial edema, and that will collapse the tubules, and that will manifest with acute renal failure as well. And the another term I would like to talk about drugs is that about analgesic nephropathy. And as we know, we use analgesics, and the most important analgesic that we use in our day-to-day practice is NSAIDs. And the mechanism of action of this drug is by inhibiting COX enzyme. And this drug, as it inhibits the COX enzyme, it will result into a decreased production of prostaglandin. And because of decreased production of prostaglandin, that will manifest with afferent arterial constriction. And as the afferent arteriole will be constricted, it will manifest with decrease in the hydrostatic pressure, and eventually decrease in the GFR. And this will manifest with acute renal failure as well. So that is known as something about analgesic nephropathy. And regarding drugs, I would like to say it once again that most of the drug causes interstitial nephritis with edema, and that will manifest with acute renal failure. And the next thing is about chemicals, and the chemical is especially about contrast material that is used especially in radiology department, and it is also one of the very important cause of acute renal failure in case of hospital settings. The next cause is septicemia, and also the next cause being the ischemia due to hypotension. Whenever there is a hypotension, or even when we talk about septicemia, it can be septicemia is due to bacteria, and the proliferation of the bacteria eventually get filtered through the glomerulus, and eventually it can lead to damage of the tubule, and eventually can manifest with acute renal failure as well. Even in case of septicemia and even in case of hypotension, there will be decrease in the blood flow to the kidney, and this blood flow to the kidney will also result into a decrease in GFR. But wait a second, I also talked that decrease in the blood flow will result into pre-renal azotemia, but it is not completely true, because decrease in the blood flow will also lead to damage to the kidney itself. Whenever there is decrease in the blood flow, that result into ischemia within the kidney, and whenever there is an ischemia to the kidney, that will manifest with ischemic acute tubular necrosis. So that I'll be talking in a moment in this video itself. So let me remind you once again. So Decrease in the blood flow can result into pre-renal cause of azotemia as well as intrarenal cause of azotemia, because decrease in the renal blood flow will manifest with intrarenal ischemia with necrosis of the tubule, and that is also one of the very important cause of acute renal failure. So let me discuss about acute tubular injury. Acute tubular injury, also known as acute tubular necrosis, and this is basically the video is about. And acute tubular necrosis, it is a clinical pathological entity. It is a clinical pathological entity. It is characterized morphologically. It is characterized morphologically by damage in the tubular epithelial cells. So acute tubular necrosis or acute tubular injury is a clinical pathological entity which is characterized morphologically by damage in the tubular epithelial cells, and it is characterized clinically by a decline in the renal function, so decrease in the renal function, and that manifests with oliguria and azotemia. So let me define acute tubular injury once again. So acute tubular injury is a clinical pathological entity, and it is characterized by acute renal failure, and often, not invariably, there is a morphological evidence of tubular injury in the form of necrosis of the tubular epithelial cell, as I've just explained in this video itself. So acute tubular injury, it is now preferred over the older term, that is acute tubular necrosis, because it is not sure sort that will find necrosis within the tubules in every sort of disease, but it is sure that we will find the injury to the tubular lining of the epithelial cells. And that is sure sort. Hence, the term acute tubular injury is used more often than acute tubular necrosis. So what happens is that, as I've said, it is a clinical pathological entity that is characterized morphologically by damage to the tubular epithelial cells. So we can see this is one tubular epithelial cell, and we cannot appreciate all the nucleus within the tubular epithelial cell. So probably there has been focal loss of the tubular epithelial cell due to ischemia in this, or due to toxin mediated, and that has led to damage to this cell, and we cannot appreciate this cell because of necrosis within this tubular epithelial cell. And so and the and because of this, there has been focal loss of the tubular epithelial cell. And also we can appreciate in morphology is that we can appreciate the tubules, within the tubules we can appreciate there is presence of a dirty brown granular crust. So there is a presence of dirty brown granular crust, and that usually blocks the tubule itself. So acute tubular injury is a clinical pathological entity that is characterized morphologically by damage into the tubules, and it is characterized clinically by a decrease in the renal function, and that manifests with oliguria or azotemia. And we can appreciate dirty brown granular cast in the tubular cell, and which can also be appreciated in the urine. So we can see dirty brown granular cast in the tubular cell, and it can also be appreciated in the urine as well. So the most common cause, as I said in the first part of this lecture, that acute kidney injury or acute tubular necrosis or acute tubular injury, it is the most common cause of acute renal failure itself. Hence, acute renal failure is also sometimes referred as acute tubular injury or acute kidney injury. So this is the reason. And whenever I said it is clinically representing with oliguria and azotemia, so what does oliguria means? It means that has been a decrease in the urine volume, and it has been decreased to about less than 400 ml per day of urine. But it is also important to know that this acute tubular necrosis or acute kidney injury, it is a reversible process, and we'll be seeing in the clinical part of this video as well. So it is a reversible process, and it has several stages of the recovery that we'll be seeing here. So what are the different causes of acute tubular injury? As I said, it can be due to two important causes. It can be due to ischemia, or it can be due to toxin mediated. So it can be due to ischemia, and it can be mediated via toxin. So ischemia means there has been severe compromise in the renal blood flow. So due to the decrease in the renal blood flow, and this will manifest with ischemia or necrosis of the tubular cells, and this will manifest with acute tubular injury. So it can be happened. It can happen. So what are the different ischemic causes? It can be due to microscopic polyangiitis. So it can be due to microscopic polyangiitis. So ischemic causes can be due to the injury it's within the renal blood vessel itself. So there can be injury within the renal blood vessel itself, and one of the cause is microscopic polyangiitis. So microscopic polyangiitis, and the next cause is thrombotic microangiopathies. So it can be thrombotic microangiopathy as well. So in both conditions, there will be decrease in the renal blood flow, or it can be that the renal blood vessel is absolutely normal, but there has been a systemic damage to the blood vessels or systemic pathology which will involve the blood vessels, and it can be due to diseases like thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, and other diseases as well. So not just that, acute tubular injury due to ischemia can happen in variety of clinical settings, and it occurs relatively frequently in clinical setting because it can occur from severe trauma. So it can occur from severe trauma to acute pancreatitis. Acute pancreatitis. We can manifest acute tubular injury in case of severe trauma, in also in case of acute pancreatitis, and not just that, even in case of septicemia as well. So in all these conditions, what happens is that there will be severe sympathetic activity. So sympathetic overtone will happen, and this will result into vasoconstriction. And this vasoconstriction will also affect the kidney, and hence there will be decrease in the renal blood flow, and this will manifest with ischemia to the tubules as well. So it can happen in this condition, and it can also happen in case of hypotension and shock. So in all these conditions, microangiopathy, thrombotic microangiopathy, and microscopic polyangiitis in case of 3T, and hemolytic uremic syndrome. It can also happen in case of severe trauma, even in case of acute pancreatitis, and even in case of septicemia because of due to sympathetic overflow. And not just that, it can also happen in case of hypovolemia and shock. And whenever this happens, there will be decrease in the renal blood flow, and this initially will manifest with pre-renal azotemia. So there will be pre-renal azotemia, and with progression of disease, that can lead to necrosis of the tubules, tubular epithelial cells, and that will manifest with acute kidney injury itself. So what are the causes? As I said, one of the causes is ischemia, and ischemia will result into decreased or interrupted blood flow, and it can happen due to diffuse involvement of the intrarenal blood vessels, or it can be due to systemic condition as well. So as I said, due to intrarenal blood vessel, the diseases can be microangiopathies, it can be due to microscopic polyangiitis, and it can also be due to malignant hypertension, because in malignant hypertension there will be deposition of the proteins in onion skin like fashion, and that will result into decrease in the lumen of the arteriole, and that will manifest with decrease in the blood flow. Even in case of systemic condition, that is like hemolytic uremic syndrome, TTP, and even DIC, that will manifest with decrease in the renal blood flow, and that will also result into ischemia. And also it can be due to hypovolemic shock, and I also said it can be due to our day-to-day clinical scenarios like severe trauma, or even in case of acute pancreatitis, even in case of septicemia, because all these things that will lead to increased sympathetic overstress, and this increased sympathetic overstress will decrease the renal blood flow, because sympathetic system will constrict the blood vessels. Not just that, it can be also due to direct toxic injury, and as I've already discussed the causes in the first part of this video. So direct toxic injury can be due to endogenous agent, or it can be due to exogenous agent. So what are our endogenous agent that is present within our blood that can damage to the kidney? So it can be myoglobin and hemoglobin. Both myoglobin and hemoglobin are heme containing protein, and this heme containing protein can damage the tubular epithelium via following ways. So this heme containing compound contain iron, and this iron will get oxidized to ferric form, and this ferric form of iron will result into formation of hydroxyl ion, and that will lead to reactive oxygen species mediated damage to the epithelial cell, and hence direct toxic injury to the tubules. Not just that, heme containing product has direct toxic effect to the tubular epithelial cell, and also heme containing product will use up the nitric oxide, and because of this there will be decreased amount of nitric oxide, and hence afferent arteriole will now be constricted, and because of the constriction of afferent arteriole, that will manifest with decrease in the glomerular filtration rate. So this is also one of the cause so of heme containing compound. Not just that, as I've said, it can be due to hemoglobin, myoglobin. It can be due to monoclonal light chain in case of multiple myeloma, and it can even be due to bile or bilirubin. So all these things can lead to direct toxic effect on the tubular epithelial cell, and hence causing the disease. And not just that, it can also be due to exogenous agent. And what are those exogenous agents? It can be due to drugs, as I've already mentioned in first part of this video, like gentamicin. Not just that, I've also talked about analgesic nephropathy. It can also be due to radio contrast dye that is used in radiology department. It can be due to heavy metals like mercury. It can be due to organic solvents like carbon tetrachloride. So everything, all of this can result into direct toxic mediated injury into the tubules, and hence causing the disease. And sometimes it can be due to a combination of ischemia along with nephrotoxic as well. So as I said, acute tubular injury can be due to ischemia, or it can be due to toxin mediated, and sometimes there can be combination of both, and it can happen in case of mismatch blood transfusion, and other hemolytic crisis causing hemoglobinuria and skeletal muscle injury. So let me explain this. So whatever whenever we are discussing in the last slide, as I discussed, so your heme containing compound like myoglobin and hemoglobin, it can lead to damage by three different mechanisms. One, it can cause direct toxin. It can result into formation of hydroxyl radical. It can result into depletion of nitric oxide. So these are the mechanisms that will result into damage to the tubular epithelial cell. So so in these first two mechanisms that led to direct toxic mediated damage, and the third mechanism, there was decrease in the blood flow resulting into ischemia. So hence both the combination happens in case of condition where we have increased amount of heme containing compound in the blood, and that will be filtered. So what are those conditions where we have increased amount of heme containing compound in the blood? It can happen in case of mismatched blood transfusion that will result into massive amount of hemoglobin, massive hemolysis, and that will result into increased amount of hemoglobin in the blood. It can also be due to other hemolytic crisis. It can also happen due to hemoglobinuria, and it can also happen due to cross injuries. So cross injury, and even in case of burns, in case of cross injury, what happens that there will be severe rhabdomyolysis. There will be breakdown of the muscles and result into increased myoglobin, and this myoglobin will result into all these mechanisms, and hence it can cause combination of ischemia and nephrotoxic, both of them. So what happens is that, as I've discussed, the critical event in development of the acute tubular injury is that it can happen due to disturbance in the blood flow, and it can happen due to tubular injury due to the toxin itself. So let us talk why our tubules are susceptible to ischemia, and why our tubules are susceptible to the decrease in the why our tubules are susceptible to ischemia, and why they are susceptible to toxin. So why our tubules are susceptible to toxin? So as I've said in all part of my video, in this video, that there are several toxins that lead to damage to the tubules. So why are our tubules very susceptible to these agents? So we know that, let us consider this is our Bowman's capsule, and this is our this is one of the tubular epithelial cell. And this tubular epithelial cell, let us consider this tubular epithelial cell. So we can see that these are our tubular epithelial cell, and these tubular epithelial cell are constantly being used up. So there will always be filtration of substances, and this substance can be toxin like drugs. It can be due to it can be radio contrast dye, it can be myoglobin, it can be hemoglobin, and all those agents that we discussed. All of them they are filtered by the glomerulus, and eventually some of the toxin and eventually these will appear into the urine. Whereas some of the toxin, as some of them, they cannot be filtered by the blood, and instead they are being secreted into the tubules, and from the tubules they are taken into the blood. And during this there is a transit time, and hence they are present into the tubules, and because these toxins are present into the tubules, they will lead to damage of the tubule as well. Also, sometimes what happens is that these toxins are being endocytosed by the tubules, and like our hemoglobin, myoglobin, they are being endocytosed by the tubules, and eventually that will result into formation of iron within the tubular epithelial cell, and that will also knock out the tubular epithelial cell. And because of the process of filtration along with reabsorption, along with secretion, especially the reabsorption and secretion part of the, and that will result into increased accumulation of toxins, and the toxin will be accumulated within the tubular epithelial cell, and that will damage the tubules, and hence manifesting with acute tubular necrosis. And the next thing is that why do we also see why our kidney is also susceptible to ischemia? So for this, let me make a kidney, and let me show. This is the cortex of a kidney. This is outer part of the medulla, and this is the inner part of the medulla. So this is the cortex, this is outer medulla, and this is inner medulla. And regarding the blood supply of the kidney, the cortex is richly supplied by the blood vessels, whereas outer medulla and the inner medulla are not so much supplied by the blood vessels. So outer medulla and inner medulla are supplied by vasa recta, and the amount of blood supply to this site is very less, and resulting into susceptibility to ischemia in case of outer medulla and inner medulla. But in both of them, especially the outer medulla is even more susceptible to ischemia as compared to inner medulla, because let me make a kidney diagram. This is our PCT. This is also our straight portion of PCT, which is located in the outer medulla, and this is the descending limb of Luca Fenley, and this is the ascending limb of Luca Fenley, which is present in the inner medulla. So this is inner medulla, this is outer medulla, and this is our cortex. So let me make this, and this is our thick part of ascending limb of Luca Fenley, and there is our distal convoluted tubule, and there is collecting duct. So we can see that there are several structures which are present in the cortex, and also several structures which are present in the outer medulla, and several structures present in the inner medulla. As I said, that the cortex has a very good blood supply, whereas outer medulla and inner medulla are not having a good supply. But it is a but that also affects outer medulla a lot more often than compared to inner medulla. As I said, outer medulla is more susceptible to ischemia as compared to inner medulla. Why does this happens? Because as we see in the outer medulla, we have PCT, proximal convoluted tubule cells, and we also have thick part of ascending limb of loop of Henle. And as we know, PCT and thick ascending limb of loop of Henle, they constantly use ATP for reabsorption purpose. So the reabsorption of the component that are being filtered, they are being reabsorbed into the blood, and during the process of reabsorption, they use up a lot of ATP, and the ATP comes from glucose, and glucose is being oxidized, and eventually it undergoes production of ATP, and for that it requires oxygen. And as we see in outer part of medulla, there was decreased blood supply, and also there is increased demand. So whenever there is a condition of renal slide to ischemia, which I mentioned in the previous part of this video, that will result into compromise in the blood flow, and especially the demand will be not be met. And because of this, the outer medulla, the component of the outer medulla, especially the PCT and the thick ascending limb of Henle, these will undergo necrosis, and this will undergo necrosis, and it is very important to know. But one might ask me, why the inner medulla, although it receives less blood supply, but why isn't it much susceptible? So as we can see in this diagram, the inner medulla consists of descending limb and ascending limb of loop of Henle, and this component of the tube of the nephron, it is not much involved in case of absorption, and it doesn't require much ATP as compared to this cell. Hence we and why this slide, I think we are clear that the outer medulla is susceptible to the injury, and outer medulla is susceptible to ischemia. So we know now that our tubules, especially the tubule, is susceptible to ischemia, and it is also susceptible to toxin. I think I have explained it, and I hope you are clear about that. So as I've discussed that there can be tubular injury, and there can be severe disturbance in the blood flow, and that lie in the pathogenesis of acute kidney injury. So tubular injury, so as we know that how the tubular injury happens, as I've said, it can happen due to toxin, and it can happen due to ischemia, because these are very sensitive to toxin and ischemia. So the next fact is that several factors will predispose the tubule to the toxin injury. I've already mentioned all of these facts, and because of there is concentration of the toxin, there has been a high rate of metabolism of oxygen, and these all factors will result into the tubules being highly susceptible to toxin and highly susceptible to ischemia. And because of that, there will be injury to the tubular epithelial cell, manifesting with necrosis of the tubular epithelial cell, causing acute tubular injury or acute tubular necrosis. And also, as I've said that as the tubules flow, so let me make a diagram to explain this. So till now, what we have said regarding the pathogenesis is that there will be tubular injury, and the tubular cell injury can happen in the form of toxin, and it can happen in the form of ischemia. So as the tubule, so let me make a diagram. So there is a toxic mediated injury. So there is a toxic injury, and there can also be ischemia. So there can also be ischemia. So this toxin mediated injury can directly result into tubular injury. So the toxin can directly damage the tubule, result into tubular injury. Not just that, the ischemia will also result into vasoconstriction, and that will also result into tubular injury. So for a moment, just leave this component. So remind that ischemia will result into tubular injury. So tubule can be injured due to toxin or due to ischemia. This we have already discussed. Okay? So what happens is that whenever there is a damage to the tubules, now the tubules will be sloughed off. There will be sloughing off of this tubular epithelial cell. As it will sloughed off, it will result into formation of a cast, and that will result into obstruction, Not just that, whenever there will be tubular injury, and this tubular injury will result into loss of polarity of cells. So I'll be explaining there will be loss of polarity of cell polarity, and because of the loss of polarity, this will result into decrease in urine output. So that will result into decrease in urine output, and that will also manifest with, and this obstruction with decrease in the urine output will manifest with decrease in the GFR. So if there is a tubular injury, that will also result into interstitial inflammation, and this interstitial inflammation will lead to collapse of the tubule, and that will also manifest with GFR, and this decrease in the GFR will result into acute kidney injury. So let me discuss all these factors. So as I've said, toxic injury, there can be injury to the tubules can be mediated by toxin, and it can be mediated by ischemia. So whenever this happens, there is a tubular injury, and once the tubule, so there has this, let us say these tubules are being injured, and because of the tubules are being injured, these tubules are being sloughed off, and now they will be aggregated, and because of this aggregation, they will form a cast, and this cast will obstruct the outflow of the tubular cells, will obstruct the outflow of the will obstruct the outflow, and due to obstruction of the outflow, that will manifest with decrease in the GFR. So I hope this component is clear. So not just that, what happens is that, let us see once again. So the next thing that I said was, there is decreased tubular feedback. So let me discuss about decreased tubular feedback. So this is our tubules, and this is our tubular epithelial cell. So normally we know that on the basolateral side there is presence of sodium potassium ATPase pump, and this sodium potassium ATPase will pump out the 3 sodium and will take yes, and it will take 2 potassium within itself. Right? So whenever there will be damage to the tubule, so whenever this tubular cell is damaged, there will be loss of polarity, and loss of polarity in a sense that this component will come here, whereas this component will go here. So now the sodium potassium ATPase will be mislocalized into this part, and now the sodium will be sent into the tubule instead of getting into the blood, and potassium will come into the tubular cells. So as the sodium is coming into the tubule, eventually it will reach the distal convoluted tubule. So it will reach distal convoluted tubule, and in the distal convoluted tubule, we have macula densa cells. And in the distal convoluted tubule, macula densa cell will know that there is increased sodium load, so it will result into production of certain substance, and this substance will result into vasoconstriction, and this vasoconstriction will cause afferent arterial constriction. So that will manifest with afferent arterial constriction. And what are these vasoconstrictive substance? It can be endothelin, or it can be, as I said, decrease in nitric oxide and decrease in the prostaglandin, and this all will result into vasoconstriction of the afferent arterial. And if the afferent arterial is constricted, so let me make glomerulus. So this is glomerulus, this is afferent arterial, this is efferent arterial. So if this is constricted, decreased amount of blood will come to the glomerulus, and less amount of blood will be filtered, and hence it will manifest with, and that will manifest with decrease in the GFR as well. So I hope you are clear about this as well. So I have explained about these factors. So the first thing was damage to the tubule. The next thing was it result into loss of polarity of cell, and this loss of polarity will result into rearrangement of sodium potassium ATPase, and that will result into abnormal ion transport and increased delivery of sodium to the distal tubule, and that will result into tubulo-glomerular feedback that will produce certain vasoconstrictor substance that will cause increase in the afferent arterial resistance, and that will result into decrease in GFR. And the next thing is that also there will be intrarenal hemodynamic alteration that will also decrease the GFR. And I have also discussed this all factor also already. So let me talk about this diagram, and I hope you'll be clear about everything that I've discussed throughout this video from this diagram. So ischemia can happen. So whenever there is ischemia, ischemia will result in tubular cell injury. And also, as I said, tubular cell injury can also be due to toxin. So whenever it can be due to ischemia or it can be due to toxin, the tubular cell will be injured. And once the tubular cell is injured, the tubular cell injury can be reversible or it can be irreversible. Once, if it is reversible, then there will be loss of polarity. And as I've said, the sodium potassium ATPase pump will come in from basolateral side into the luminal side, and that will pump the sodium into the tubule. And because of this, there will be increased sodium delivery into the distal convoluted tubule, and that will result into tubulo-glomerular feedback. And this tubulo-glomerular feedback happens, and that will result into vasoconstriction of afferent arteriole. And the afferent arterial vasoconstriction happens because there is increased amount of endothelin and decreased amount of nitric oxide and prostaglandin, and that will result into vasoconstriction of afferent arteriole. And this will also manifest with reduce in GFR, and that will result into oliguria. Not just that, if there will be tubular cell injury, whether it be reversible or irreversible, and irreversible can happen in the form of necrosis or apoptosis, and this can result into detachment of the cell, and that will result into obstruction of the tubule by the cast. And whenever there will be obstruction of the tubule by the cast, that will result into increase in the intratubular pressure, and that will oppose the glomerular filtration rate, and hence that will result into decreased GFR, and that will manifest with oliguria. So also not just that, whenever there will be damage to the tubules, so and we can also see that there has been damage to the tubules that has led to formation of cast within the tubules, and also there will be backflow of the blood of the filtered, and this backflow will happen, and this will result into the fluid will be leaking into the interstitium. So this is the interstitium, and these are the tubules. As the tubules are damaged, the fluid will be leaking into the interstitium, and this condition is known as tubular back leak, and that will also result into decreased tubular flow, and because of the decreased tubular flow, it will also result into reduced GFR. Also, this tubular back leak will result into interstitial edema, and even it will result into interstitial inflammation, and that will result into collapse of the tubule, and that will also manifest with oliguria. I hope by this chart you might have understand all the factors that has led to acute renal failure, and that is all due to the tubular cause. So now let us talk about the morphology. I hope you will be clear about morphology if you are clear about the pathogenesis part of the video. So in case of morphology, we should divide the morphology of ischemic acute tubular necrosis and the toxin-mediated acute tubular necrosis. So basically, ischemic and toxin-mediated acute tubular necrosis are very similar. Only there is a slight difference that I'll be discussing in later part of video. So let us begin with ischemic acute tubular necrosis. So as I said, there will be ischemia to the tubular cell, and that will result into necrosis of short segment of the tubule, and especially that there will be necrosis of the tubule, and I think you will be clear by the fact that there will be damage to the tubule in the outer part of the medulla because of decrease in the blood flow and increase in the oxygen demand, and that will happen into the straight portion of the proximal convoluted tubule and the thick ascending limb of loop of Henle, but it can entirely involve the proximal convoluted tubule and distal convoluted tubule as well. So no other tubule are being spared, but the most common site being the straight portion of the proximal convoluted tubule and the thick part of the ascending limb of Henle. So we can see, so this is our proximal convoluted tubule, and this is the medullary part that will be undergoing necrosis, and also this. So let me clear this. And we can also see the thick ascending limb of loop of Henle, which is also present in the outer part of the medulla, and this will also undergo necrosis, but no part of the tubule is spared. It can involve any part of the tubule, but the most common site being the PCT and the thick ascending limb of loop of Henle. So we can see that in the tubular cell, as I've said, the tubular cell will undergo necrosis, and we can appreciate there is loss of cells. So we do not see any cell here. And also we can appreciate that within the tubular cell, there is aggregation of a dirty brown granular cast, and that can especially be appreciated in the distal convoluted tubule. So let me explain why do we see this dirty brown granular cast in the distal convoluted tubule and not in the other part of nephron. So we can see that there is focal loss of tubular cell, and there are also tubule are blocked by the cellular debris. So let me discuss why do we see the cast in the distal tubule and not in the early part of the nephron. So so let me make a nephron here. So this is PCT, this is thin descending limb, this is thick ascending limb of loop of Henle, and this is the distal convoluted tubule. So we should be knowing the fact that the thick ascending limb of Henle is secreting a cast, and that cast is known as hyaline cast. And this hyaline cast is being secreted in the thick ascending limb of Henle, and this is actually termed horsefall protein. And this hyaline cast is being secreted by the thick ascending limb of loop of Henle, and it will travel into the distal part of the nephron. So the hyaline cast will present in the distal tubule, and as we know, the tubular epithelial cell will be sloughed off, and this tubular epithelial cell will coat the hyaline cast. See, this hyaline cast is being coated by tubular epithelial cell, and this tubular epithelial cell now will be present in the distal part of the tubule, especially in the distal convoluted tubule and the collecting duct. Hence, we can see that there will be sloughing of the, hence we can appreciate that the presence of the hyaline cast, or not hyaline cast, there will be presence of the dirty brown granular cast, especially in the distal tubule and especially in the collecting duct. So this is why we appreciate the dirty brown granular cast in the distal tubule and not in the early part of the tubule, because the formation of the cast happens in the distal tubule itself, because the thick ascending limb of loop of Henle will be secreting the hyaline cast, and this hyaline cast will be coated with the dislodged or sloshed out the necrotic tissue, and eventually that will be forming in the distal tubule and the collecting duct. Okay? So we can appreciate variety, but as I said, the name acute tubular necrosis is not commonly used. Instead, we use acute tubular injury nowadays, because it is not that we'll always see necrosis in the tubular epithelial cell. We can also see a different pattern of injury. So what can we be appreciated into the different pattern of injury? So as we know that the proximal convoluted tubular cell on their luminal side has gross border, and due to the injury, as I've said, due to there is decrease in the ATP, and because of decrease in the ATP, the sodium potassium ATPase will not work, and now the sodium cannot be pumped out of the cell, and instead the sodium will be inside the cell, and that will result into accumulation of water with sodium, and that will result into swelling of the cell, and hence there will be loss of the proximal tubular gross border cell. There will be bleeding of the cell with sloughing of the gross border. Also there will be vacuolization of the cell, all because of the fact that I mentioned just now. Also there will be detachment of the tubular epithelial cell from the basement membrane, so it is attached to the basement membrane, and now they will be detached from the basement membrane, and eventually the slough of cell will be appearing into the urine, or they can even form the hyaline cast, or not the hyaline cast, they can coat the hyaline cast and eventually form the dirty brown granular cast, and that is also pathognomic. So we can also appreciate the eosinophilic hyaline cast that is pigmented, and also along with that we can appreciate the pigmented granular cast, which is formed by the hyaline cast, which is coated by the cells, and that can be appreciated in the distal tubule and the collecting duct that I've already discussed. And as I've said, the cast consists of a protein that is known as term Horsfall protein, which is actually normally being secreted by thick ascending limb of loop of Henle along with other plasma protein, and this is being coated by the necrotic cells or necrotic debris, and hence forming the dirty brown granular cast, and it can be appreciated in the distal convoluted tubule, and also in the and it can be appreciated in the collecting duct. So we can see the green color represents the cast, and this green color can be appreciated through the distal convoluted tubule and can also be appreciated in the collecting duct. However, we cannot see the green color cast which is present in the proximal convoluted tubule and thick ascending limb of loop of Henle, but instead what we can appreciate is that we can appreciate necrosis. And necrosis can be appreciated in the proximal convoluted tubule and also in the thick ascending limb of loop of Henle. So you should be knowing at what side you will see the necrosis, and you should be knowing at what side you will appreciate the dirty brown granular cast. And it is usually the necrosis can be appreciated in the proximal tubule, especially the straight part of the proximal tubule, which lies in the outer medulla, and the thick ascending limb of loop of Henle that also lies in the outer medulla, whereas the cast can be appreciated in the distal tubule and the collecting duct. And as we know that the interstitium, as I have already said, there can be tubular backlit. So this is a tubule, and as there has been damage to the tubular epithelial cell, so this has been damaged. And what happens, there is also increased intratubular flow. So the tubule is loaded with high pressure fluid, and this fluid will leak into the interstitium because the tubular cells has been damaged, and it will leak into the interstitium, and the interstitium will show generalized edema. Along with that, as I said, there can happen the chance of interstitial inflammation as well, and due to infiltration of polymorphonuclear leukocyte along with lymphocyte and plasma cells that happens in the interstitium, that results in interstitial edema with interstitial inflammation. So as I said, so this is all about the ischemic, the morphology that we appreciate in ischemic variant of acute tubular necrosis. And we can also see similar changes in case of toxin-mediated acute tubular necrosis with some slight variations. And one of the very important variation is that the basement membrane is spared in case of nephrotoxic acute tubular necrosis, whereas other changes are very similar. And what we can appreciate in the nephrotoxic variant is that there will be diffuse involvement or diffuse necrosis of the proximal convoluted tubule. So the cells of the proximal convoluted tubule, as I said in the ischemic variant, we appreciate necrosis mainly in the outer medullary compartment, especially in the straight part of proximal convoluted tubule. But in case of nephrotoxic ATN, basement membrane is spared, and there is diffuse involvement or diffuse necrosis of the proximal convoluted tubule segment, and also there can be necrosis that happens in the ascending limb of loop of Henle as well. So these are all the differences that you will be manifesting in case of nephrotoxic versus ischemic ATI. So now if the patient will survive for a week, then the process of epithelial regeneration happen, and eventually there will be formation of low cuboidal epithelial, and there will be a mitotic activity in this cell, and that will try to regenerate the epithelium lining with the tubules, and eventually the tubular morphology will be will be normal in the day to day in the coming days, and that will result into recovery of acute tubular necrosis. And let me now talk about the so let us first see the different morphology that we can appreciate. So as we can see, all the we'll try to summarize what we have already seen. So we can appreciate the normal glomerulus in this diagram, and what we see is that we can appreciate the normal distal convoluted tubule. So we can see the DCT is absolutely normal, but within this distal convoluted tubule, we can appreciate this cast. So within the DCT, we can appreciate the cast. So DCT is normal, and we can within the DCT we can appreciate cast. Not just that, we can appreciate these proximal convoluted tubular cells, and we can see that the proximal convoluted tubular cells, the lining epithelium is entirely necrosed. See, we cannot appreciate any cells which is lining the PCT cell, and we can also appreciate this necrotic debris which are present within the PCT. So by this, we know about the morphology on acute tubular necrosis. So let us talk about the clinical course that I was beginning to discuss. So it usually has three courses, and that is divided into three stages of the recovery in acute tubular necrosis. And the first stage is known as initiation stage. So first stage is known as initiation stage. So in the initiation stage, it lasts for about 36 hours. So this initiation stage lasts for about 36 hours, and it is characterized by slight decrease. There is slight decrease in the urine output. So there is slight decrease in urine output with rise in the blood urea nitrogen. So BUN and creatinine will be rising, and there will be just a slight degree of oliguria, and it is probably because there has been decreased blood flow in the early part of the disease. So this all manifest with decreased blood flow in the early portion of the disease. And as I've already discussed, why there is decreased blood flow, because there is increased production of vasoconstrictor substance and decreased production of vasodilator substance, and that will manifest with decreased blood flow. And if there is decrease in the blood flow in the initial course of disease, especially in the initial 36 hours of the disease, that will manifest with slight decrease in the urine, and there will be formation of blood, there will be increased level of BUN and creatinine. And this is our first stage, and this is known as initiation stage, which lasts for about 36 hours, and that is characterized by slight decline in the urine output manifesting with oliguria, and there will and thereby rise in the blood urea nitrogen and the creatinine value. So the next stage is our maintenance phase. So the next stage is maintenance phase, and this maintenance phase will start from the second day, or it can also start on the sixth day, depending on the initial stage, right? So the maintenance stage will start on the second day, or it can even start on the sixth day. And whenever it is started, and it will basically last for hours, or even it can last for up to 3 weeks. So it can last from hours to up to 3 weeks. And in this condition, there will be severe decline in the renal function, severe decline in the tubular function, and that will manifest with oliguria. So there will be oliguria. And not just that, because of oliguria, as the filtration has been compromised, so there will be retention of salt and water. So the salt and water will be retained in the body, and that will manifest with volume overload or water overload. Not just that, it was the duty of the kidney to filter out hydrogen ions and the potassium ions. And now, as the GFR has been compromised, there will be hyperkalemia and acidosis. So hyperkalemia with acidosis can also be appreciated with rise in the BUN and creatinine ratio as well. So increase in the BUN and the creatinine as well. That happens in case of the maintenance phase. So let us see the maintenance phase. So it is characterized by sustained decrease in the urine output, and the urine output will decrease to such an extent that there will be decrease in the urine output up to 40 ml of urine per day, and that is very severe. Along with that, there can be salt and water overload and rising level of BUN and creatinine ratio. Along with that, there will be hyperkalemia and metabolic acidosis, and all the manifestation of uremia that we can appreciate in the patient. And with appropriate management, so the patient can overcome this oligouric crisis, and eventually they can recover. But it is the matter of fact to know that it is in this stage where we can see maximum amount of death due to ATI, or due to ATN. So the maintenance phase should be maintained efficiently, and there should be prompt dialysis if it happens. So there should be maintenance of this properly, and with prompt dialysis should be done in this case, because it is a very severe case. And managing the patient in this stage will determine the death and the living and the livelihood of the patient as well. So the third stage that we will be discussing is the recovery stage. And in the recovery stage, there will be now what happens that our body will try to compensate, and it will try to increase in the GFR. And because of the increase in the GFR, the amount of filter urine will be more. And also there will be management, and the BUN and the creatinine, also the potassium and hydrogen ion will be filtered out, and eventually they will appear in the urine. But mind you, the fact that there has been damage to the tubules, and the recovery to the tubules will take days to come. And because of this, as the tubule are still damaged, it cannot concentrate the urine. And because the tubule cannot concentrate the urine, the amount of urine will increase, and it can even rise up to 3 liters per day, because the tubule are still damaged. So large amount of water and sodium and potassium are lost in the urine. So it can, as the potassium are lost, but still, as I've said, the hydrogen ion cannot be secreted, because it is being secreted via the tubular epithelial cell, and it can result into increased acidosis, and this hydrogen ion will enter the cell. And in this way, it will also result into increased amount of potassium leaking out of the cell, and that can manifest with hyperkalemia. But it is not as severe in case of maintenance phase, because recovery phase is quite good. And it is still in this recovery phase, we can find 25% of the death due to acute tubular injury happen due in case of recovery phase. So in this stage also, there is also increased vulnerability of infection. There can be complication due to hyperkalemia, and 25% of death can happen in recovery phase. So it should be managed promptly, and the dialysis should be done if it is required. So in this way, we will manage, and we can appreciate the different stages or different clinical features of acute tubular necrosis. So I think I have completed a lot of portion in this video, and this video will be very long. So I hope you have understood a lot of things in this video. I hope you will revise this video time and again, so that you will get your clear concept on this acute tubular injury. And the next video will be about chronic kidney disease. Thank you very much.